So our next speaker is Timothy Henry, who will talk about revascularization in ACS, shock. Does the type of stent matter at all?
Let's see, do I have it?
Let's see what happens.
Well, if you want me to do risk models.
And we'll restart the timer for you, don't worry.
We'll add.
All right, let's see. Is it going?
There we go.
Okay, so this is easy. No. Beyond DES is better than bare metal stent. And if, you know, it's interesting because we did the invasive management of acute MI shock. We talked about everything. I don't think the type of stent ever even came up. So it's not an issue, but what is the data? So if you remember back, this is a Horizons AMI trial published in the New England Journal. And basically, drug-eluting stents are better than bare metal stents. And tons of data that shows that, mostly because they prevent restenosis. So the acute events is really no different. So is there any data in cardiogenic shock? There's actually a couple trials, and this is like 300 patients in each group that looked at a durable polymer versus biodegradable polymer. Absolutely no difference. So with the new generation of stents, absolutely no difference, not any difference in any group. And this is actually the Clear Synergy Oasis 9 trial. What you notice from that last is the events once you leave the hospital are extremely low. And this is the Clear Synergy and a STEMI trial. Stent thrombosis at 24 hours, 0.3 at 1 year, 1%. Very low event rates in a STEMI population. So in acute MI, really doesn't matter with the new generation stents. What does matter? The type of revascularization matters, so it's primarily PCI. Rarely do we use cabbage. But there is an important issue. What about patients who are more than 120 minutes away? And actually, if you look at the pharmacoinvasive trials for STEMI, doing a pharmacoinvasive approach actually is beneficial, and getting transferred to a SPET that has PCI. And we just published data in Circ Intervention that shows that, in fact, with the University of Alberta, that if you're a long distance from a PCI center, giving lytics first actually makes a difference in cardiogenic shock. Less cardiogenic shock, and you do better. So this is an important addition to our revascularization and data that, because I think prior we would have said giving lytics in cardiogenic shock is really not a useful thing. Now, what about the time to revascularization? This also matters. And we're not doing that great. So this is data that we published in December. And one of the keys for STEMI is time to treatment. And if you look at this, the actual median times published in the American Heart Association registry were really long. And if you're transferred, the average time is 240 minutes. Only 17% of patients transferred from a non-PCR center were treated in under 120 minutes. And the odds ratio of dying if you were treated in under 120 minutes versus over was 0.44. It's 4.4% versus 14. And that also correlates with the development of cardiogenic shock. So the type matters, and doing it quickly. Another thing that's really important that matters is antiplatelet, and we don't talk about it. So if you look at this, we've learned over the last decade that the balance between ischemia and bleeding is very important, but almost all of the events occur in the first 6 hours. So that's the critical importance of antiplatelet therapy. And in STEMI, in cardiogenic shock and out-of-hospital cardiac arrest, you have a huge issue because there's decreased bioavailability, you have the morphine fentanyl issue, you have ventilation, you have people vomiting, people can't take oral agents. So there's a lot of things that add up to inadequate antiplatelet therapy. And this is the data that shows fentanyl, morphine does the same thing, that there's delayed uptake and of effect of antiplatelet agents. This is what happens if you look at clopidogrel and STEMI with cardiogenic shock. You really don't have antiplatelet therapy for 12 hours. And this is actually data with ticagrelor and prasugrel in just STEMI patients, and you don't have antiplatelet therapy for 6 hours. That's why all your events are in the first 6 hours. So this is Cangelar, and this is actually shows that there's a theoretic advantage to doing it because you have an immediate onset of antiplatelet therapy. This is the Cantic trial, which randomized Cangelar to crushed ticagrelor, and you can see that basically in the first 3 hours, you had almost no antiplatelet therapy with ticagrelor, in contrast to immediate outcome. So this is something that we should be thinking about. There's really strong theoretical advantages for Cangelar, and I think the problem with 2B3 inhibitors is there's excess bleeding. So this is, I think, something we should build into the trial. And is it important? This is data from RECOVER-3. Culprit shock registry and the culprit shock trial showed the same thing. Only 85% of the patients actually had TIMI grade 3 flow. So if PCI is the most important thing, we should be doing good PCI, and we're not. Because we're having, if you look at all cardiogenic shock out-of-hospital cardiac arrest trials, the TIMI 3 flow is 80 to 85%, most likely because they have inadequate antiplatelet therapy. So this is actually data from the Midwest STEMI Consortium, where we pre-treat aggressively in all 4 sites, and we actually have a lower incidence of cardiogenic shock, and patients present less severe, and they also have better TIMI grade 3 flow rates, including both pre and post PCI. So I think it's something to think about. When you have shock teams, in your shock algorithm should include antiplatelet therapy. And then I'm just going to end quickly with the last thing that matters is successful and complete revascularization. And this is, some of your audience are going to say, oh no, we're not supposed to do that in cardiogenic shock. So let's think about that. This is the data from the complete trial that shows complete revascularization is better than not incomplete revascularization. The question is, how do you determine what's a significant lesion and the timing? And the timing is out to 30 days or 40 days is probably okay, but the longer you wait, the more events you have. In cardiogenic shock, 60 to 80% of patients have multivessel disease. And of course, the culprit shock trial showed us that doing culprit only was better acutely. But that's the rest of the story. If you looked at 1 year, no difference once you left the hospital. And if you did culprit only, what you did is the patients who had culprit only had a significant rate of recurrent revascularization. So it's complete revascularization, but not at the original time. But you don't forget complete revascularization in these patients. At some point in time, you need to do that. So this is actually the Complete 2 trial, which is going to look at the benefit of using physiology or OCT in terms of more complete revascularization. So the type of stent doesn't matter.
Nicely done. Questions from our panel or comments?
Great talk, Tim. Really important topic, especially around the Cangelar. We really debated this very heavily for the RECOVER-4 trial design. One of the challenges with implementing Cangelar in a protocolized manner is availability of the drug, European versus US.
Yeah.
The drug is still fairly expensive compared to oral antiplatelet. So can you tell us a little bit about what you recommend, for trial design? There also hasn't really been a trial of Cangelar in cardiogenic shock. Do we need a more specific targeted trial in Cangelar shock to get a little more data behind it? And also, how would you advise, when we're doing RCT development in the use of Cangelar? Should it be protocolized or recommended?
Yeah, I think you should protocolize it. And I think personally, the issue is we have been talking about MCS and other things so much that we forgot about talking about just really good PCI. And it's funny because I actually, in reviews and discussion with culprit and culprit shock registry, there was we had excellent angioplasty. And TIMI 3 flow was 82%. That's not excellent angioplasty, right? We would never accept that. Even in STEMI, TIMI-3 flow is 98%. Regular PCI, it's 99%, right? So we should be requiring a PCI where we have TIMI-3 flow, and I think the best way to do that is with antiplatelet therapy. 2B3 inhibitors are fine, they just cause more bleeding. And so I think Kingler is the perfect choice right now.
Any other comments from our panel?
All right, I'll let you guys discuss.
Thank you so much.